Good afternoon, everyone. Thank you, Dr. Poliana Escanio, for that very kind introduction. Thank you to the UP Medicine webinars, and thank you to the UP class of 1997 for inviting me for this wonderful opportunity. For today, we will be discussing a disease that many of our doctors may not be familiar with, even if they may be talking to a patient with this condition. This condition that I am referring to is called inflammatory bowel disease. As this topic and the scope is very complicated, I will just be going over the basics like ABC. I have no disclosures. The learning objectives for today are, number one, to recognize the clinical scenario when to consider inflammatory bowel disease in a primary care or non-gastroenterology clinical setting. Number two, to get a general overview of the two types of IBD, ulcerative colitis and Crohn's disease, as far as their clinical presentation, diagnosis, and management. So this will be our lecture outline. First, we will have a case presentation, followed by a definition of the inflammatory bowel disease. Then we will have the epidemiology of IBD, followed by a short discussion on the pathogenesis of IBD. Then we have some information for you on ulcerative colitis. Then we will go over Crohn's disease. Then we will combine the overall treatment discussion, and then I'll give you take-home messages. So for our case presentation, JC is a 26-year-old Filipino male with a 1-year history of lower abdominal pain, which is sometimes associated with meals. He does have recurrent bloody diarrhea with no vomiting, no fevers, no cough, and he has difficulty gaining weight. He's seen by an internist and was noticed based on the labs that he has anemia and hypoalbuminemia. He was referred to a gastroenterologist and an endoscopy workup was done, and the diagnosis that was given was gastritis and colitis in the left colon and in the ileocecal area. The biopsies were read by the pathologist, and they were deemed as non-specific, with the assumption that this could be gastrointestinal tuberculosis. The patient was treated with 6 months of anti-tuberculous treatment of quadruple therapy. The patient had initial improvement of pain and bleeding on anti-COX medicine. However, the symptoms recurred. 1 year later, the patient presented with a bowel obstruction at the ileocecal area, and he actually had to undergo a right-hand colectomy. The surgeon submitted the specimen to the pathologist, and it showed transmural inflammation, no malignancy, negative for caseating granulomas, which is usually found in tuberculosis. At this point, the Crohn's disease was strongly considered, and the patient was referred to the medical city. So as you could see in this particular patient, there was delay in diagnosis that led to complications, like in this case, gastrointestinal obstruction. So what is inflammatory bowel disease? It refers to two chronic idiopathic inflammatory disorders. You have the ulcerative colitis and Crohn's disease. How do we define IBD? So it is defined by a constellation of characteristic, clinical, endoscopic, and histologic features critical for the diagnosis of IBD. Also, you have to remember, inflammatory bowel disease is a chronic condition, so it's not something that's acute, which is characterized by relapsing and remitting episodes of inflammation. So you need to have endoscopic findings, histopathologic findings, and sometimes radiographic findings would be helpful to your diagnosis. However, there is no single individual finding that is absolutely diagnostic. And then this is the reason why a lot of our doctors, including our gastroenterologists, have really trouble diagnosing inflammatory bowel disease, whether it's ulcerative colitis or Crohn's disease. So as a physician, like a gastroenterologist who will be seeing a patient who's presumed or suspected to have IBD, you should act like a private investigator or police officer like Sherlock Holmes. You need to look for important clinical clues in the history suggesting IBD. So, as far as duration of symptoms, in a patient with IBD, the symptoms should be chronic. Okay, and symptoms usually presented are diarrhea, abdominal pain, and other GI symptoms. So if the duration is usually acute, especially here in the Philippines, it's most likely from infectious cause. If it's chronic, then you need to consider non-infectious causes like IBD. Are the bowel movements, are they bloody or non-bloody? The presence of rectal bleeding usually suggests an invasive process like inflammatory bowel disease. However, there are also infections like bacterial pathogens that could also cause an invasive process. And having bloody stools is against a functional disorder like IBS, irritable bowel syndrome. The presence of systemic symptoms like fever, anemia, and nutritional status point to a chronic inflammatory process. So you will see there could be leukocytosis, there could be hypoalbuminemia, and the patient's hemoglobin hematocrit could be low because of chronic bleeding. And you need to know the risk factors or exposure to rule out the other differentials for colitis or IBD. So if they are immunocompromised, like HIV, the use of antibiotics and radiation could also help you establish the diagnosis by ruling out the other conditions. Age of the patient. You usually think of IBD in younger patients, although we have seen a number of patients who were diagnosed to have IBD much later in life. So here, this is a picture of a colon which has colitis. And the problem with having a colonoscopy showing this one, it will not show you that this is ulcerative colitis or Crohn's disease because the endoscopic appearance of the other differentials can look similar. Okay, for infection, you consider both acute and chronic causes like parasites. Amoeba is a very important differential diagnosis. Bacteria like E. coli, Salmonella, Shigella. Mycobacterium is very important, and this is the reason why in the past, especially in the last decades, uh, patients have been misdiagnosed to have GI tuberculosis when they actually have Crohn's disease, all ulcerative colitis. And viruses like CMV can also present like this type of colitis. Of course, inflammatory bowel disease, whether Crohn's or ulcerative colitis. Ischemia in the right clinical presentation could also present like a colitis like this. Drugs and antibiotic-induced colitis could also present like this. Radiation-induced colitis, so you need to watch for, get information whether the patient had radiation treatment before, like in cases of prostate cancer. And other rare causes of colitis like eosinophilic enterocolitis. So inflammatory bowel disease, as I said, is composed of ulcerative colitis and Crohn's disease. For ulcerative colitis, the hallmarks of ulcerative colitis include the following. Number one, it is limited exclusively to the colon. Okay. Number two, the inflammatory process is confined to the mucosal layer. So it's just the innermost lining of the colon. And there is a continuous ulcerative process, usually starting from the rectum progressing proximalward. So as I said, it invariably starts and involves the rectum and may extend to the more proximal portions of the colon in a continuous fashion. So you have these terms ulcerative proctitis, ulcerative proctosigmoiditis, left-sided colitis, and pancolitis. So here you have proctitis, proctosigmoiditis, left-sided colitis, extensive colitis, and pancolitis. Okay, how about Crohn's disease? What are the hallmarks of Crohn's disease? First, there is transmural inflammation and is characterized by skip lesions, so it's not continuous, and it may occur anywhere in the GI tract. Unlike in the colon, it only occurs exclusively in the colon. The most common areas of Crohn's disease are in the distal ileum and the proximal colon. The transmural inflammatory nature of Crohn's disease may lead to fibrosis, leading to complications like strictures, obstruction, and fistula formation. UC and Crohn's disease have both distinct pathologic and clinical characteristics, as we pointed out. However, there could be those rare cases that they can overlap and the diagnosis can actually be difficult, trying to determine if this is Crohn's or ulcerative colitis. As far as the epidemiology of inflammatory bowel disease, it occurs worldwide, but the highest is among the Anglo-Saxon Americans and Northern Europeans like Scandinavians, British, Dutch, other parts of Germans. There is a much lower incidence in South America, Asia, and Africa, suggesting that there is a genetic component. In Asia, there has been an increase in incidence in developed countries where the rate of IBD rises with urbanization. And both sexes are equally affected. Overall, ulcerative colitis remains slightly more prevalent than Crohn's disease. So this is a graph showing the age and sex incidence of inflammatory bowel disease. So as far as the age of onset, it is most common between the ages of 15 to 30 years old, although IBD can present at any age, and there is a suggestion that there could be a second peak later in life. So this is a slide which I borrowed from Dr. Jose Soliano. This is on inflammatory bowel disease in the Philippines, and they collected data from 2000 to 2012. The prevalence rate for IBD in our country is 1.57. The incident rate is 0.16. As you could see, there's more cases of ulcerative colitis than Crohn's disease diagnosed in the Philippines. And as you could see from years 2000 all the way to 2012, there is a rise in the diagnosis of these cases. Is this really due to low prevalence in the Philippines or low diagnosis in which our gastroenterologists are not actually recognizing the disease even if it's in front of them? Now let's go to the pathogenesis of IBD, just an overview. The pathogenesis of IBD is a result of interplay between the genetic, environmental, intestinal barrier, and immune response. So as you can see, genetics play a role. That's why there's more Europeans and Anglo-Saxon Americans are affected with disease. There are also environmental factors like smoking, diet, use of medication, and the microbiota that could influence the development of IBD. Also, there could be problems with intestinal barrier, and the individual probably has some form of immune dysfunction. So here, I will show you what happens in a healthy gut and in an IBD gut, okay? So in the healthy gut, you have the normal microbiota. The intestinal barrier is actually intact since this person has a healthy GI tract. And the immune system is functioning. There is tolerance and there is homeostasis. What happens in IBD? So with IBD, there is actually the microbiota has kind of changed. There is reduced diversity and there is dysbiosis. So what is dysbiosis? It is an imbalance in the gut microbial community that is associated with disease. So in simplest terms, it just kind of means that the bad bacteria is predominating over the good bacteria. So that's what we think is happening in IBD. And then you also have a disturbed intestinal barrier. Because of the condition in the gut of the IBD, there is because of the intestinal barrier being not intact, you have increased penetration of luminal antigens. Plus, you have a dysregulated immune system. Instead of the immune system being tolerant and trying to have homeostasis within that microenvironment, what is happening is the immune system becomes very hyperactive and attacks the own self uh, elements in the GI tract. And then you add the genetic component, as we mentioned, the people who have from North America and Anglo-Saxon and Northern Europe, they tend to be more affected with IBD. Plus, these following environmental factors can bring about the development of IBD in a patient that is predisposed. Okay, what about nutritional factors and diet factors? The Westernized diet create a pro-inflammatory gut environment and they alter the gut microbiome. And with this one, they end up compromising the epithelial barrier function and then predisposing the patient to develop IBD. As you know, Westernized diet are high in protein, they have unsaturated fat, and they have reduced amount of vegetable, fiber, and fruit. And this will lead to lower microbial diversity, higher levels of the bad bacteria, and alterations in host immunity and intestinal barrier, which you find in IBD patients. Okay, the most common symptoms of IBD are usually abdominal pain, diarrhea, fatigue, weight loss, fever, and rectal bleeding. Okay, then let's start with ulcerative colitis. So the most common clinical symptoms of ulcerative colitis are bloody diarrhea, which is usually frequent and small in volume, and they could range from 3 bowel movements to 10 bowel movements per day. They could have colicky type of abdominal pain. They could have urgency. They have tenesmus, which is a feeling of incomplete evacuation. And sometimes they could be incontinent. Okay. The onset of these symptoms is usually gradual, so it does not happen overnight. Sometimes what happens is symptoms are very progressive over several weeks, so patients tend to downplay their symptoms and they hope it will get better, but they just progress with time. And once you have systemic symptoms like fever, fatigue, and weight loss, these are usually severe. Okay, going over the natural history of ulcerative colitis, these attacks of blighted diarrhea can usually last for weeks to months, and these are what you call flares. With treatment, the course of ulcerative colitis consists of intermittent exacerbations or flares alternating with long periods of complete symptomatic remission. However, there is a small percentage of patients that have chronic symptoms and are unable to achieve complete remission. So what is the Copenhagen criteria? So this is how you can diagnose ulcerative colitis. And all criteria must be present to diagnose ulcerative colitis. So the patient should have that history of diarrhea and or rectal bleeding for more than a week or with repeated episodes. I would probably say at least 4 weeks, since more than a diarrhea of more than a week is so non-specific, especially in our setting, it could be still infectious. There has to be characteristic endoscopic findings of continuous ulceration, vulnerability, or granulated mucosa, as you can see in this picture. And then once you do histopathology, there has to be consistency with chronic changes of ulcerative colitis in which you have neutrophils with epithelial structures, in which you have a chronic inflammatory reaction, and you have changes in the crypts, like crypt distortion and destruction of the crypt architecture. So here, I think we did mention before that ulcerative colitis can be classified as whether this is just proctitis or proctosigmoiditis, and then you could have left-sided colitis, and then you could have pancolitis. So if you have colitis beyond the splenic flexure, that's already pancolitis. Okay. How do we work up and what diagnostic tests do we do for a patient that first we are suspecting ulcerative colitis, and for patients who are known to have ulcerative colitis and we're not sure if they're having a flare or not. So you could get a complete blood count, get some electrolytes to find out the patient may be dehydrated and they need to be supplemented with their electrolytes. See if the kidney function is okay with a creatinine. You could get an ESR and the CRP, and these are markers for inflammation, and these are really good for establishing flare and doing surveillance of the patient with IBD. You could check for an albumin to find out if they are hypoalbuminemic. And you need to do stool tests each time because you want to make sure that this is not an infectious process. And also sometimes an infectious process can predispose a flare of the patient with IBD. And you need to treat both that flare and you need to treat the trigger. So you need to submit stool cultures looking for this bacteria, get a fecalysis looking for ova and parasites like amoebiasis and giardia, and fecal calprotectin and lactoferrin, which are inflammatory markers in the stool, and they are actually very characteristic of IBD, but they can also be found in other inflammatory disorders. Having a normal fecal calprotectin can rule out functional disorders like irritable bowel syndrome. And there are other special tests like these autoantibodies, the p-ANCA and the anti-Saccharomyces cerevisiae antibody, which can be done. It is available in an institution here in Metro Manila. p-ANCA is more common in ulcerative colitis, and the ASCA is more common in Crohn's disease. However, these are not requisite for diagnosis, and even you have a positivity or a negativity of this, you still need to follow the standard criteria, which was mentioned in the Copenhagen criteria. And STD tests, if indicated, since there are other diseases like Neisseria gonorrhea and other sexually transmitted disease that can produce proctitis. Okay. Next step in the diagnosis would be a colonoscopy. So, ileocolonoscopy, you want to take a look at the colon and you need to take a look at the terminal ileum. Okay. So, this is a picture of the normal colon. This is the picture of the cecum, and this is the ileocecal valve. Once you are in the cecal area, and if you have the colonoscopy here, you want to enter into the ileocecal valve to see if the terminal ileum is normal. Because if the terminal ileum is abnormal, then this is not ulcerative colitis, but can be Crohn's disease. Okay. What are the endoscopic findings of ulcerative colitis? As I told you earlier, this is a normal colon, very smooth and shiny colon, normal vascular markings. Here, this is ulcerative colitis. So you have extensive ulcerations with exudates, and then you could have polyps, pseudopolyps, and when extensive, they could look like this. Okay, pseudopolyposis. Okay, what do you see on the biopsies from the samples that we get from a colonoscopy? So biopsies of the colon obtained on endoscopy are necessary to establish the chronicity of the inflammation. Because if the inflammation is chronic, you will see changes that can characterize by a predominant lymphocytic infiltrate. And then you will see distortion of the crypt architecture, which you don't see in acute process. Okay, so here, this is an abnormal colonic mucosa. As you can see, there's a lot of lymphocytic inflammation, and here the crypts have already lost their architecture. So you see signs of chronicity, and this criterion will help you establish that this could be ulcerative colitis. Okay, and the severity of ulcerative colitis can be classified. There's a couple of classification. I will just discuss two ways. The first one is the True Love and Wits classification of ulcerative colitis. So you have mild, moderate, severe, and these are the different criteria. So under mild, usually the number of bowel movements is less than four. They could be a little bit bloody. They will not have a fever. They are not tachycardic. They don't have anemia, and their ESR is less than 30. They have severe ulcerative colitis if they have more than six bowel movements. They have a very large amount of blood in their stools. They're febrile, they're tachycardic, they have anemia, and they have an elevated ESR. If they're in between mild and severe, then they have moderate ulcerative colitis. Okay. The other the other classification that we will be talking about is the Mayo scoring system for the assessment of ulcerative colitis. So in Mayo, it may look simpler, but it does require endoscopic findings. So you go over stool frequency, which is included in the True Love and Wits, rectal bleeding, okay, which is also included in the True Love and Wits. These two are new. So you have the physician global assessment. So this is relatively subjective on the part of the physician. So it's like zero is normal, one is mild, two is moderate, three is severe. And then you need to do at least a sigmoidoscopy or a colonoscopy to complete the Mayo scoring. So zero would be normal, one would be a very mild inflammation, two would be moderate inflammation, and three would be severe in such case in which it's very, very friable. The moment the scope touch the lining, there is already spontaneous bleeding, and that's severe. And if you total them up, so four criteria times three, so the score will range from 0 to 12. And the higher the scores will indicate a more severe disease. What are the complications of ulcerative colitis? So you could have acute complications, you could have chronic complications. Acute complications could be bleeding, you could have fulminant colitis and toxic megacolon, which may be a surgical condition and is characterized by a dilated colon, the patient's having fever, leukocytosis, patient's just too toxic. And fortunately, if the patient is not treated urgently and appropriately, it can lead to a perforation of the colon. Chronic complications because of the recurrent inflammation can lead to stricturing of the colon. So you could have a stricture in ulcerative colitis, and there is a risk for colorectal cancer. Okay, so this is a benign stricture. As you can see here, the scope may not be able to pass through here, and this is best represented here by this barium enema. And this is a malignant stricture. And the only way to differentiate benign and malignant is obviously do a biopsy. Okay. And also, as we mentioned, there is a significant risk for colon cancer. So as you can see here, the risk of colon cancer increases with the duration of the symptoms. So for pancolitis, the risk increases after 8 years of onset of the disease. While, however, for those with left-sided colitis, it usually starts around 12 to 15 years. So for patients with inflammatory bowel disease, especially ulcerative colitis, they need to have their colorectal cancer screening earlier. As you know, in the Philippines, the accepted start age of screening is at 50 years old. For Americans, they've lowered it to 45. Patients with IBD may start screening in their 30s or even late 20s if they have their disease relatively early in life. Okay, so we've discussed about ulcerative colitis. Now let us go to Crohn's disease. As you can see, in contrast to ulcerative colitis, Crohn's disease is a heterogeneous inflammatory disorder, and it could affect any sites of the gastrointestinal tract from the mouth to the anus. And it is usually characterized also by a high rate of stricture formation and penetrating disease complications like fistula. Okay, so the Montreal classification, since it's a very heterogeneous disease, they divide it into Montreal L category, which stands for location, Montreal B category, which is really more on the phenotype or behavior of the disease. So L1, if it only involves the terminal ileum, L2, if it involves the colon, L3, if it's both ileum and colon, L4, if there is upper GI tract that is involved. And for L4 plus L3, it means there is lower disease and there is upper disease as well. As far as behavior or phenotype, they could be B1, which means there is no stricture formation and it's not penetrating type. B2 is stricturing type. B3 is penetrating type. And B3P, you see the P here, stands for perianal penetrating disease, like those patients with Crohn's who have perianal fistula. Okay, so what are the hallmarks of Crohn's disease? And I think we mentioned the phenotypes. So there is transmural inflammation. When you say transmural, it involves the entire wall of the colon or the small intestine. And as in contrast to ulcerative colitis, you actually find skip lesions in which the disease segments alternate with normal segments. And the disease can be in just plain inflammatory, which is just luminal disease, stricturing, in which you do have strictures along the way, fistulizing, and then perianal disease. Okay, what are the clinical presentations in Crohn's disease? Okay, they could have chronic pain and diarrhea. The pain is actually more of a prominent symptom in Crohn's compared to ulcerative colitis. The diarrhea could be less bloody compared to those in ulcerative colitis. They could also have signs of inflammation like fever. They could present with bowel obstruction, like what happened to our patient. And this, you have an X-ray that showed bowel obstruction. You have dilated small bowel loops, okay? And they could all present with abscesses and fistulas because of the transmural inflammation and the penetrating type of presentation. Okay, and so how do you proceed to diagnose Crohn's? Obviously, for a gastroenterologist, it would be through endoscopy. And since it can affect both the upper and the lower GI tract, we usually do pan endoscopy. So we will do an upper endoscopy. We visualize the upper GI tract from the mouth to the duodenum. And then we do a colonoscopy, which visualizes the lower GI tract from the anus to the terminal ileum. So there's actually a portion of the digestive tract which cannot be covered with these two endoscopies. And if needed, I'm not saying this is really entirely necessary. You could use a capsule endoscopy. However, in the Philippines, a capsule endoscopy is so expensive. And if you already have inflammation that we could document through an upper endoscope and a colonoscopy, you may not necessarily need to do a capsule, and sometimes radiographic tests can be enough. Okay, so what are the endoscopic findings in Crohn's disease? So you could have this aphthous ulcers. These are small, shallow ulcers. You could have longitudinal ulcers, so their axis is like the long axis of the colon. And if you have intersecting ulcers of the longitudinal and the transverse ulcers, you could have cobblestoning here. Okay. Okay, what are the findings on histopathology? So you could find transmural inflammation, as we discussed before. Then you have the presence of granulomas, which you do not see in ulcerative colitis. And they are the non-caseating type, because those that are found in tuberculosis is the caseating type. So if you find a caseating type of granulomas, then that is tuberculosis. But if you have non-caseating granulomas, it could be Crohn's, but it could still be tuberculosis. And the problem with these granulomas is they are only found in less than 30% of cases of Crohn's disease. So if you don't find a granuloma, it can still be Crohn's. Okay? So as I mentioned, for Crohn's disease, then you may need to do radiographic exams. So like a regular abdominal X-ray, like what we showed you earlier, maybe an upper GI with small bowel follow through, and then you could do a CT scan. So you have the CT enterography, and then you have the magnetic resonance imaging and the MRE. So the gold standard actually, as far as radiographic test of the small bowel, would be MR enterography in inflammatory bowel disease. And in some countries, but not hardly done here, there is intestinal ultrasound in which we could actually see if there's inflammation in the colon and the small intestine and could be used as a surveillance test. Okay, so how we define the severity of Crohn's disease? Remember, we had True Love and Wits and the Mayo Clinical Score for ulcerative colitis. Here, we actually use the Crohn's Disease Activity Index. Okay, it is a validated instrument to measure the signs and symptoms of Crohn's disease. And these are usually used in clinical trials, and the score is like 0 to 600. And these are the 8 components. And each component has a weighing factor, like, the number of liquid stools in 7 days, abdominal pain, general well-being, extraintestinal complications, taking antidiarrheal, presence of abdominal mass, hematocrit, and body weight. The problem with this grading system is it's actually very complex and it's not easy to do in the clinics. And I would be surprised if even our gastroenterologists are actually doing this in other busy clinics, since as you can see, there is even a factor per item. Okay, but this is definitely used in clinical trials. Okay, what are the complications? So here, the complications for Crohn's disease are more unfortunate than the one in UC. Around 15 to 30% of patients with Crohn's disease will develop perianal visualizing complication, which understandably is really like, a really bad condition to have. And the fistulas arise from the epithelial barrier defects caused by persistent inflammation. And sometimes the abscess, you have an abscess here that can eventually lead to a fistula. Okay. So the fistula could be perianal. It could be from intestine to intestine, and it could be from like large going into small. And these are some examples. So you have an enterocutaneous fistula, which is a fistula from the bowel going to the skin. This is enterofistula, so from one part of the intestine going to another. And this is a picture of the perineal fistula. Okay. Inflammatory bowel disease, both UC and Crohn's disease, can also present with extraintestinal manifestations. Okay. And these are manifestations that you would not think are actually related to the disease. And around 1/4 of them will actually have extraintestinal manifestations throughout their lifetime. So it could be as simple as arthritis, and you could have ankylosing spondylitis, which they call as the bamboo spine, the fusion of uh, the lower vertebra, the lumbar vertebra, and they could have eye symptoms like uveitis and episcleritis, and they could have erythema nodosum, which are this like purplish or red tender nodules on their extremities. These ulcerated areas called pyoderma gangrenosum. And there's also a condition in the liver associated with patients with inflammatory bowel disease in which they have a stricturing bile ducts. So that condition is called primary sclerosing cholangitis. And patients with IBD are actually at high risk for arterial and venous thromboembolism. Okay. So what are the features that are in favor of Crohn's over ulcerative colitis? Because sometimes, it may be difficult to distinguish one of the other. So chronic pain and having diarrhea in the absence of gross bleeding more or less point to Crohn's rather than ulcerative colitis. If you have perianal disease, that's automatic Crohn's disease. If you have fistulas, that's automatic Crohn's disease. As far as the pattern of disease that you may see on X-ray or endoscopy, the absence of rectal inflammation is more on Crohn's and most likely not ulcerative colitis. If they have small intestinal involvement, then it is Crohn's. And if you have skip lesions, as we define, that is Crohn's. And if you have granulomas on biopsy, that is also Crohn's. Okay, so this is just a table differentiating the two. Rectal bleeding or hematochezia is more common in ulcerative colitis. Small bowel disease is yes in Crohn's. Upper GI involvement in Crohn's. Extraintestinal manifestations in both. Fistula and perianal Crohn's. P. ANCA, ulcerative colitis. ASCA, more in Crohn's. Transmural inflammation, Crohn's disease. Granulomas, Crohn's disease. Deep lesions in Crohn's. Okay. There is also another condition which can be confused with Crohn's disease. And then this is probably what was happening uh, for decades in the Philippines, that a lot of our doctors may not have been recognizing Crohn's disease and all conditions that kind of look like tuberculosis or Crohn's were actually treated as tuberculosis of the GI tract. As you can see, uh, the findings can be similar on endoscopy. And also, Crohn's disease, the area that is most affected is the ileocecal area. However, also in tuberculosis, that is also the area that's most commonly affected. Okay, so here just in tabular form to differentiate Crohn's versus GI tuberculosis, as you could see that a lot of the symptoms can be seen in both conditions, like fever, hematochezia, diarrhea. TB could also present with fistula. They could present with extra intestinal manifestations, similar type of ulcers. They could have similar clinical background. But if you find caseating granulomas in the biopsy, if you find a positive acid fast bacillus on the biopsy, those are definitely for TB. But the problem is not all patients with GI tuberculosis will have caseating granulomas and acid fast bacillus. And in TB, you could also find necrotic lymph nodes that are greater than 1 centimeter. Okay, so now going to treatment. So the goals of therapy for both Crohn's disease and ulcerative colitis are more or less kind of the same. You want to induce and then maintain remission. You want them to be off corticosteroids. You also want, in addition to a clinical remission, they don't have any symptoms. You also want their endoscopy findings to be normal. So you want endoscopic remission and you have the fistula remission for patients with Crohn's disease. Since they'll be on medicines, you want to reduce the serious adverse effect and induce treatment tolerability. Okay, but for both conditions, you actually need psychosocial support and improve quality of life, since this is a condition that will be with them for the rest of their lives. And you want to prevent cancer and you want to promote mucosal healing. So, what are the medicines that are used in inflammatory bowel disease? So, you have the 5-ASA, the 5-aminosulates like mesalamine. You have corticosteroids. Usually we use prednisone or budesonide. We have immunomodulators like azathioprine, mercaptopurine, and then we have the biologics. Okay, so let's start with the simplest medicine, which is mesalamine. We call it here in the Philippines mesalazine. That's a 5-ASA. In patients with IBD, there is a mucosal production of arachidonic acid metabolites like prostaglandins and leukotrienes. And what the mesalamine does is it decreases the inflammation by inhibiting the enzymes cyclooxygenase and lipooxygenase in the colon, which in turn blocks the production of prostaglandins and leukotrienes. So it kind of inhibits the bacterial peptide-induced neutrophil chemotaxis. And this medicine is only active intraluminally, so it's not absorbed. And is effective in inducing remission in mild forms of UC. So they may not be enough for moderate to severe types of UC. It is also effective in maintaining remission. So you want to induce remission and then maintain remission in UC. However, as far as Crohn's disease, It's really the data is a little bit not as solid. The guidelines, a lot of the guidelines don't even include mesalamine in the treatment for Crohn's disease. Okay, then we have steroids, corticosteroids, and the reason why they work is they are used to control the inflammation during the acute flares if the condition did not respond with 5-ASA. So what it does is it downregulates the inflammatory cytokines in IBD, as we know what steroids do. However, they are not used as maintenance medicines due to their a lot of side effects. Okay, and you guys know all of this from medical school. And the most common medicine that we use here, and it's not expensive, is prednisone. There is another steroid that can also be used, budesonide. It's more expensive. The advantage is it has a high first pass metabolism. So a lot of it is eliminated uh, to the liver, and the only small amount is actually absorbed. And its effects is also mainly from the topical action. It has less side effects, so it's better as far as side effect profile from prednisone, and there is minimal adrenal suppression. However, it is not as rapidly effective as prednisone. It is more expensive. However, it is able to achieve remission in Crohn's disease, but not in ulcerative colitis. Okay. And the next category would be immunoregulatory or immunomodulator drugs. So what it does is it actually inhibits the T cell function, which is involved, as you know, in the IBD pathogenesis. However, they cannot be given acutely since it requires 2 to 3 months for them to work before we see the beneficial effects. So they are not really useful in acute flares. So in patients who have acute flares, you may have to give them steroids or use the medicines that we will be discussing after immunomodulators. It is actually effective long term since it can diminish corticosteroid requirements. So you can start with steroids and start with the immunomodulators, and hopefully in 2 to 3 months, you're able to taper them from prednisone, and then these immunomodulators will start working and they could keep the remission continue. However, there are also side effects, which include bone marrow suppression, hepatotoxicity, even pancreatitis. Okay, so now going to the next category of the medicines that we'll be discussing in treatment for IBD, both UC and Crohn. So you see, this is the healthy state that we discussed earlier, and this is what's happening in IBD. And there's actually a lot of mediators of inflammation that are happening here. And one of them would be the TNF, the tumor necrosis factor alpha. So there are medicines that were formulated and produced to fight against the TNF. And you have the interleukin 12 and 23 inhibitors, since interleukin 12 and 23 are also one of the mediators of inflammation that are implicated in IBD. And also, there are also medicines that have been produced that we call our leukocyte trafficking and adhesion inhibitors. What it does is once this goes to the circulation, they kind of block the lymphocytes from going into the inflamed area, and these are new medicines, the sphingosine phosphate receptor modulators. Okay, so what are biologic agents? So this is our final category for treatment in IBD. So this is a class of drugs that are produced by living organisms such as bacteria or mammalian cells in culture. It consists of large and complex molecules and are often protein-based. They are produced through biotechnology in a living system such as a microorganism, plant cell, or animal cell. They provide, as I showed in the previous slide, a more targeted approach to reducing inflammation in the form of monoclonal antibodies against tumor necrosis factor, interleukins, and integrins. However, due to the high cost of these drugs, especially in the Philippines, there are constraints in making them widely accessible in Asia. Okay, so the biologic agents are your other alternatives other than steroids, which you can use for induction and maintenance of remission and moderate to severe IBD. So the first to come are the anti-TNF, the anti-tumor necrosis factor agents, and these are antibodies to TNF that I showed earlier. The first medicine that came out is infliximab, which is a chimeric IgG monoclonal anti-TNF alpha, and it's given through IV infusion. As we mentioned, the TNF is produced by macrophages expressed at high levels in the colonic mucosa of IBD. So if you give them antibodies to TNF, then the inflammation will decrease and the patient will get better as far as their symptoms are concerned. The other anti-TNF that came out eventually are adalimumab, golimumab, and certolizumab. However, there are side effects for this medicine because they kind of suppress your immune system because in IBD there's hyperactivity of the immune system, so you're giving the medicines to suppress their immune system. So naturally, infection like sepsis are among the side effects. The patient can have a tuberculosis reactivation, especially if they have latent tuberculosis. You give them anti-TNF, they can develop TB. They could have worsening of hepatitis B. So hepatitis B needs to be checked before you put them on anti-TNF. And long-term use, there's a concern that it could lead to lymphoma and there could be hematologic toxicity as well. So another medicine, which is relatively new compared to the other medicines, is anti-interleukin 12-23 antibody. So ustekinumab is the name of this medicine, and it is a human anti-interleukin 12/23 antibody, which inhibit receptors in T cells, antigen-presenting cells, and the induction phase is given IV, but the maintenance is given subcutaneous. So this is much more convenient for patients. So they just get the induction dose IV, and they could get the subsequent doses subcutaneous. So this is the interleukin 12, and then you have the interleukin 23, and then this is the ustekinumab. So it prevents the interaction, the interleukin with the receptors on the cells. So basically, you block the inflammation that would have been produced if you have interaction the interleukin with the receptors. So here, so interleukin 23 and 12 is black. So basically, you are blocking more steps in the inflammation in IBD. Okay, there's another kind of medicine, which is an anti-integrin antibody, and it's called vedolizumab. So with vedolizumab, it is a humanized monoclonal antibody to alpha-4 beta-7 integrin, which is a mediator of gastrointestinal inflammation, resulting in the blocking of the entry of inflammation-stimulating lymphocytes. So look at the diagram here. So this is the GI tract with inflammation, okay? And then this is the endothelium, okay? So you have this T cell, okay, and it attaches to the a receptor here in the endothelium, and this is what we call a gut-homing T cell. So it kind of goes back to from the lymph nodes. It goes back to the inflamed GI tract, and as you could see, once there is an interaction between the MADCAM and the T cell, the lymphocytes can actually go in, and it further aggravates the intestinal inflammation that's already happening in the gut. However, if you have vedolizumab, okay, it blocks the interaction with the MADCAM and the endothelial cell and the lymphocyte. So there is no infusion of these lymphocytes into the lamina propria of the digestive tract. So this is how it works. So The good thing about vedolizumab is gut selective anti-inflammatory body. So there is less side effects on the patient compared to the anti-TNF because this one is gut selective uh, biologic. Okay. So when you induce remission in a patient with IBD, it has to be followed by maintenance medicine. And usually the maintenance medicine would be the biologics or it could be the immunomodulators. Or for very mild cases, it could be the mesalamine. Okay. So the overall approach in treating the patient IBD, there's actually two ways. And uh, you have the step up therapy versus the top down therapy. So I will just discuss each and I'll show you the diagram. With the step up therapy, you're starting with least least expensive, a milder medicine, and then you go up to the more potent medicine. So you start with medications that are less potent and associated with fewer side effects, like you could start with mesalazine. And if the therapies are ineffective, you could go with immunomodulators. More potent medicines are used, so you could go with biologics. The other approach is a top-down therapy in which you start with more potent therapies such as biologics and immunomodulators relatively early in the course of this disease. So here you go. So this is the step up, which is conventional approach. You start with 5-ASA and then control their flares with corticosteroids, put them immunosuppressives. If they don't respond, then you put biologics, and then they will go to surgery if biologics don't work. This is the step-down approach. In patients, you actually start with biologics, especially if you know they will get worse with time, especially if you actually diagnose them late in their disease. So this is the top-down approach. And this is actually the approach that is used in the United States and Europe and not so much in Asia, especially in the Philippines, since the biologics are very expensive and doctors are still hesitant since they're not comfortable using biologics. Okay. If worse comes to worse, in which the patient is not responding to biologics, they can go for surgery. So these are the indications for surgery. Uh, Patients are really toxic and they have a risk for perforation. So you really need to bring this patient to surgery rather than have the patient perforate, and it's much harder to treat the patient. If they're having exsanguinating hemorrhage, sometimes if their visualizing disease is not controlled, if they're having a bowel obstruction, like what happened to our patient here, if there's cancer, obviously you need surgery, or if there is significant dysplasia, or just plain intractability, the patient's not responding to medicines. So my take-home message for this session, and I hope you guys learned something about IBD, is as physicians, either in your primary care setting or non-gastroenterology clinic setting, please consider inflammatory bowel disease in the right clinical setting, especially in those patients with recurrent and chronic gastrointestinal symptoms. So refer the patient to a gastroenterologist if you're thinking this could be IBD. And ulcerative colitis and Crohn's disease can be differentiated from each other in most clinical situations. So thank you very much for this opportunity, and I'm ready to answer your questions. Thank you.